Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 53rd virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Enhancing Hip Health, Strategies for Preservation and Reconstruction, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Do you know which joints are the strongest joints in your body? Your hips. The hip joints are essential for mobility and are involved in every step you take, and each time you get up and down from a chair, from the floor, you get the idea. We use and rely on our hips a lot. As a result, as we age, our hips experience significant use, which can lead to wear and tear, and for some people, that wear and tear can result in decreased mobility and discomfort. Tonight, Brian Schwartz, MD, will talk us through different strategies for optimal hip health and hip function. Dr. Schwartz practices in IBJI's Grays Lake and Libertyville locations and is a board-certified orthopedic surgeon, fellowship trained in hip and knee reconstruction and total joint replacement. He received his undergraduate degree from the University of Wisconsin-Madison and then attained his Doctor of Medicine at the University of Illinois College of Medicine. Dr. Schwartz then went on to an orthopedic surgery residency at the University of Illinois and completed his training with a fellowship in total joint arthroplasty at Harvard Brigham and Women's Hospital at Harvard University in Boston. He focuses on the preservation and reconstruction of the musculoskeletal system, specifically on his patients' hips and knees. Building trust with my patients is of key importance, says Dr. Schwartz. At all times, I put the patient's best interests first and work toward a treatment path that best suits the individual's needs. For example, when I was reading through the Google reviews of Dr. Schwartz, one of his patients said, "I went in thinking I was going to need a knee replacement, but after consulting with the doctor, we decided to try some other options first, which are working out exceptionally well." And another said, "Dr. Schwartz performed my right hip replacement surgery. I could not be happier with the results. Dr. Schwartz is the reason why I am walking today. He changed my life." Different strategies, both leading to happy patients. His areas of expertise include direct anterior hip replacement, outpatient hip and knee replacement, minimally invasive joint replacement, computer-navigated hip replacement, revision hip and knee replacement, custom patient-specific knee replacement, and arthroscopic surgery. During Dr. Schwartz's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Schwartz immediately following his presentation. I do ask that you please keep your questions general, as Dr. Schwartz will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Schwartz via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Schwartz, please mark your calendar for our next IBJI and YMCA Education Series program. On Wednesday, July 24th at 7 p.m., physical therapist Regina Roderick will discuss telehealth, Rehab Revolutionized. Thank you again for joining us tonight, and thank you, Dr. Brian Schwartz, for your time and your effort in putting together this program to help us learn about how we can enhance our hip health. Dr. Schwartz, please take it from here.
All right, Karen, thank you for that intro. Thank you to everyone for joining us this evening. All right, can everybody see this?
Yep, I do believe.
All right, so thank you again for that intro. My name is Brian Schwartz. I'm a board-certified orthopedic surgeon with fellowship training in hip and knee replacements. And tonight we're going to be talking about enhancing hip health, strategies for preservation and reconstruction. So let's get started. And first off, I want to say, I'm in the shark room in my son's bedroom. I'm trying to hide from my children so we don't have too many distractions. So enjoy the shark room. All right. So a little bit about me. I grew up in Riverside, which is a western suburb of Chicago. I went to undergraduate at University of Wisconsin-Madison and then med school and residency at the University of Illinois. And then I did my fellowship in hip and knee replacements at Brigham and Women's Hospital out in Boston. And so we're going to keep it informal, so please feel free to message the moderator with any questions, and we'll go through them at the end. There we go. All right. So overview, we're going to talk about different causes of hip pain, and then we'll focus on, hip osteoarthritis, which is very common. We're going to discuss what that is, the scope, the epidemiology, then we'll discuss preventative measures, and then we'll talk about non-operative treatment options, and finally we'll talk about the surgical treatment options for that. So this talk's going to be based or founded in evidence-based medicine. Evidence-based medicine is basically having science and scientific studies to back up the things that we talk about and the things that we recommend for patients. And the American Academy of Orthopedic Surgeons has put together evidence-based medicine guidelines. And you can go to this website, orthoguidelines.org, and you can read all about many different orthopedic conditions. And they basically summarize all the orthopedic scientific literature and give recommendations on how strong or how weak the evidence is for different things. So highly recommend checking that out. So what's the first thing that we talk about when they come in for hip pain? Really want to know the location of the pain. So there's really three main categories or buckets, like I like to say. So the first category is patients come in and they have pain in their lower back, buttock, pain traveling down their leg, radiating down their leg, weakness, numbness, tingling. We usually think that's coming from the back. The second most common area of hip pain we see is pain on the side of the hip or on the outside of the body. And we'll talk about different causes of that. And then lastly, some patients will come in with pain in the front of the hip or in the groin. This can radiate to the buttock as well or down in the knee. And that's usually what we think of pain coming from the joint itself. So low back pain, again, this is in your lower back, buttock, classically people call it sciatica. And oftentimes this is related to issues in your lumbar spine, whether you have herniated discs, stenosis, scoliosis, sprains, strains. Sometimes you can have fractures or something called spondylolisthesis, where the vertebra shift. A lot of times patients come in for hip pain and it's really their back, and usually we help with therapy and some kind of get MRI. The other common pain that people come in is pain on the side of the hip. This is very common, and most of the time this is something called greater trochanteric pain syndrome. And what this is, it's a spectrum of these different things. So it can be bursitis. So bursa is a sac of fluid. You have them all over your body. There's one that lives in the side of your hip, and when it gets inflamed, we call it bursitis, and it causes a sharp pain on the side of the hip. Oftentimes patients say they have difficulty laying on this or getting in and out of a car or a chair. You can also have tendonitis of the tendons on the side of the hip, which falls into this syndrome. And then sometimes you can actually have tears of those tendons, whether they're or full thickness tears, and that's found typically on an MRI. But most of the time we try to treat this non-operatively, whether it's do nothing, rest, ice, anti-inflammatories, physical therapy. Steroid shots work well for this. Once in a while we'll do PRP injections if the steroid shots aren't working. But if it persists, we typically get an MRI. And if there is a tendon tear and it's persistent for a long period of time, sometimes we'll do surgery for this. And then the last, category or location of hip pain is pain in the groin or pain in the front of the hip. This is typically what we think of as coming from the joint, and it can radiate to the buttock, it can radiate down to the knee. Sometimes it can only be in the knee, and the pain is actually coming from the hip. That's what we call referred pain. But the causes of hip joint pain, most commonly is hip osteoarthritis, which is what we're going to focus on for the rest of this talk. But you can have other things like inflammatory arthropathy, like rheumatoid arthritis, psoriatic arthritis. You can have something called avascular necrosis, and that's where the blood supply to the ball or the femoral head of the hip joint goes away and the head begins to collapse. You can have hip dysplasia, and that's where the socket is too shallow, and you can have a torn labrum. That's the cartilage bumper around the ball and socket joint, and that can get torn. Sometimes it can just be, a muscle strain or a sprain. So what actually is hip arthritis? And first to understand that, you have to understand what is the hip joint. So the hip joint is the femoral acetabular joint, is what we call it in medicine. It's a ball and socket joint, and it connects the thigh bone or the femur to the pelvis. So the upper end of the femur is called the femoral head, and this is the ball. And this goes in the pelvic bone socket, which we call the acetabulum. And the femoral head and the acetabulum, or the ball and the socket, are covered by what we call articular cartilage, and this is a slippery tissue that reduces friction and allows the joint to move smoothly. So what is hip osteoarthritis? Hip osteoarthritis is wear and tear of this articular cartilage, and this happens over time. It can be age-related or trauma-related, and when this cartilage wears away, the bones start to rub on the bones, and this is what causes the pain, the stiffness, the limited mobility that people see with hip arthritis. So again, you can think of the articular cartilage as the white shiny stuff on the end of a chicken or turkey bone. It has a very low coefficient of friction, which means it basically functions as ice gliding on ice, and it's actually smoother than that. And when this wears away, that's what we call osteoarthritis. So how does this look radiographically or on x-ray? So this is a normal hip from Dr. Google, and you can see by these green lines, there's a space between the ball and socket, and that space, again, represents the articular cartilage. And then this is a really arthritic hip, and you can see there's no space between the ball and socket. All that space is gone, and you can see these cysts, or these dark circles within the socket and the head. That's what we call subchondral cysts, which are a side effect of arthritis, and you can see all these white bone spurs, and that's what we call osteophytes. And these are all findings of osteoarthritis, and that's what that looks on an x-ray. And then again, this is just an arthritic hip on the left-hand side of your screen, and you can see there's no space between the ball and socket. And then what they're calling a normal hip, not normal, but still left. You can see that dark space there. So hip osteoarthritis, what does this feel like? Like we talked about, it's typically pain in the groin, in the thigh, in the buttocks. It can travel down the leg to the knee. Sometimes you'll feel catching, or what we call crepitus, which is a grinding noise, and that's when the bones rub on the bones. It can cause weakness in that leg. You know, and arthritis is funny. The symptoms will kind of fluctuate over time, but over time it tends to get worse, and it really begins to affect your quality of life. And you'll have, you know, decreased range of motion, problems putting on your shoes and socks, and cutting and painting your toenails. You know, eventually it keeps you from being active and walking, and eventually it will keep you up at night, and it just drives people nuts at the end of this. So what are some risk factors for developing hip osteoarthritis? You know, number one, age. Obviously, the wiser you are and the more miles you put through your hip, you know, the more likely you are to wear out your joints, including your hip. You know, sex. So women who are postmenopausal are more likely to develop hip osteoarthritis than men. Obesity. So if you carry a little bit more weight, then that can put more force through your joints, including your hip. And genetics, that tends to run in some families. So, you know, in my family, you know, my grandma had a hip replacement, my uncle had a hip replacement, my aunt, who's a nun, had a hip replacement, my dad had his hips replaced. So sometimes it kind of travels in families. You can have structural or developmental abnormalities. This includes, again, hip dysplasia, where the socket's too shallow. You can have something called SCFE, which is basically a childhood growth plate fracture of the hip joint, which can set you up for hip problems later on in life. There's something called femoral acetabular impingement, or FAI for short. And basically that's where the ball and socket are a little bit misshapen, and that can set you up for hip problems later on in life. You know, your occupation, you know, if you're in a heavy duty job, or certain types of sports that lead to repetitive motions that place stress on the hip joint, this can increase the risk for developing hip problems, including osteoarthritis. You can have an injury, whether it's a work-related injury or, you know, a fall. This can also damage the cartilage and lead to what we call post-traumatic arthritis. And then diabetes and vitamin D deficiency also increase the risk for developing hip arthritis. All right, so, you know, this is a very common condition, you know, one of the most common chronic conditions in the United States. It affects more than 32.5 million Americans. So basically 1 in 4 adults in the US may develop some symptoms of hip arthritis, so it's extremely common. And then this is looking at the projected demand for hip replacements in the United States. And it's projected to increase by 174% from 2005 to 2030, you know, reaching almost 635,000 procedures per year by 2030. So what can we do to prevent this? So preventative measures, you know, so while it may not be completely possible to fully prevent hip arthritis, you know, lifestyle changes can help reduce the risk of developing it and slow its progression. So what are some things you can do that are simple? You know, maintain a healthy weight, exercise. You want to do low impact activities like walking, cycling, swimming, and water aerobics. Physical therapy is very helpful. You want to avoid aggravating activities. Those include high impact things like running, jumping, and you want to kind of transition to more low impact activities like cycling and swimming, you know. And what keeps us in business here on the North Shore is paddle tennis, and that's pretty tough on your joints in the winter for sure. So All right, non-operative things. So let's say you do have hip arthritis, what do you do? So this is not cancer, it's not heart disease, it's not going to kill you. So option one is you can just leave it alone, live with it. That's fine. And like we talked about, you're going to have good days and bad days. It fluctuates. But overall, at some point in the future, it may get worse and begins to, affect your quality of life. And that's when you may want to consider doing something about it. Option two, you could do physical therapy. That's been shown, again, strong evidence that this helps people with early to moderate hip arthritis. So low impact exercises, muscle strengthening, maintaining range of motion. Another thing that you can do to help slow it is you can lose weight. So every pound you lose up top, you get 7 pounds less force to your knee and 5 pounds less force to your hip. So say you lose 10 pounds, you get 50 pounds less force to your hip, and that makes a difference. And that's going to slow the progression of the disease, but also make you feel better. And if it's real bad, you can use a walking aid, whether it's a cane or a walking stick or a walker, and that helps take weight off your hip. And again, will make you feel better. But obviously, that's not something that people want to do for the rest of their lives, but it does help. Option three, you can take, pain medications. Some people just do Tylenol or acetaminophen. NSAIDs work really well as well. Those are non-steroidal anti-inflammatory drugs. Those are things like Advil, ibuprofen, Aleve, naproxen, Celebrex, meloxicam. There's topical gels like Voltaren. Those all help or do really well for musculoskeletal pain and arthritic pain. You can't be on that stuff forever because it's not good for your stomach and your kidneys, and Tylenol is not great for your liver. But it can help with the bad days and help you get along if you do have arthritic pain. And you really want to avoid narcotics. Narcotics, as we know, they're addictive. They have all sorts of negative side effects to them, but also if you take them chronically for arthritic conditions, it ends up amplifying your pain over time. Your brain creates more receptors for narcotics, and it ends up actually worsening your pain. So that's not recommended to take for arthritic pain. Oftentimes patients will ask me, does glucosamine chondroitin help? And unfortunately, the evidence suggests that it does no better than placebo. And there's strong evidence to support not using this, but I don't think it can hurt. And if you want to try it, and it works for you, the placebo effect works. So if you feel better, you think you feel better, then by all means take it. But the studies suggest it's no better than, excuse me, a sugar pill. All right, moving along. So option four is injections. And there's different types of injections. There's corticosteroid or steroid injections or cortisone injections. Then there's the gel injections, which is really more so for knees and hips, but we'll talk about that briefly. Plasma injections, that's where we take some of your own blood, we spin it down in a centrifuge, and it concentrates the healing factors, and we inject it back in. And then people love to ask about stem cell injections too, which we'll briefly talk about. So intra-articular steroid injections, these are cheap, commonly used and effective. And this definitely gives people temporary relief of their pain. They can think of it as a temporary Band-Aid. It works better for shoulders and knees. It seems to last longer for those joints, but for some hips, it does give people long-lasting relief. And we could do this, as frequent as every 3 months. The downside of the shot is, again, it doesn't fix the problem. Sometimes it does not last that long, and it does increase the risk of infection after surgery. So if you get a shot and then you decide you want to get your hip replaced, we typically make patients wait about 3 months from the time of the shot to the time of the surgery, just to minimize that risk. And again, this isn't like Barry Bonds or Sammy Sosa steroids. These are corticosteroids, steroids that help bring down inflammation, not anabolic steroids. So viscose supplementation injections, or the gel shot, or Synvisc, or Zimmergel 1, or the Rooster shot, or the Rooster comb. This is more so used in knees and hips. It's typically not approved by insurance companies for hips, and there's strong evidence against its use in hips, as stated here from the ortho guidelines for the American Academy of Orthopedic Surgeons. So that's something we typically do not do, only on a very rare occasion. If a patient requests it and they're willing to pay for it, we'll do it. But I would never do this myself or recommend it to any patients for their hip, that is. And then PRPs are platelet-rich plasma injections. This is something that's newer. Initially was considered experimental, but there's some studies that suggest it does work for mild to moderate arthritis. It doesn't regrow your cartilage, but I would think of it as an expensive anti-inflammatory shot that may give you some pain relief. And this is a meta-analysis, which basically is a study that looks at many different studies. And their conclusion was there's low and moderate quality evidence that suggests PRP reduces pain and improves the function at the endpoint of as compared with baseline. And again, sometimes we'll do this in mild to moderate arthritis, but oftentimes it's not covered by insurance and can be somewhat expensive. So it's not usually our go-to. And then lastly, stem cell injections. I get commonly asked about stem cell injections, and my spiel is, the long story short is, this is a complete scam. There's no evidence that it works for hip arthritis. It may work for other things, but not for this. I tell people that insurance companies know it doesn't work, so they do not pay for it. I mentioned to patients that I trained at Harvard, because I did, and there's no doctors or scientists at Harvard that I'm aware of that routinely treat hip or knee arthritis with stem cell injections. So why would a guy in a strip mall in Lake County, Illinois, figure it out before the army of doctors and scientists at the pinnacle of Western education? And they didn't. They're just scamming you out of $10,000. So I wouldn't waste any time, money, or thought on that. And then, so when you fail non-operative management and you're the appropriate age and you have the appropriate symptoms and the appropriate x-rays, and it's really affecting your quality of life, that's when you and your surgeon may discuss surgical options. So really the mainstay is hip replacement or total hip arthroplasty, but just to be complete, there's hemiarthroplasty or partial hip replacement, and there's also something called hip resurfacing, which is not nearly as common, but we'll briefly go through those. So hemiarthroplasty or partial hip replacement, this is just where you replace the ball or the femoral head, you do not replace the socket. This is typically performed in elderly, sicker, less active patients that come into the hospital with hip fractures. It's not commonly done for hip arthritis, so that's the end of that. We're not going to talk about that anymore. There's also hip resurfacing. This is, instead of replacing the ball, you're putting a cap on the ball. The advantage of this is it preserves some bone, and in some cases you can put in a larger ball, which helps with stability. And there's some people that say it allows for running better than hip replacement. The disadvantage is you're putting a metal surface on a metal surface, so you have a metal on metal articulation, and that can sometimes pose problems. It's typically done with more surgical trauma or a larger incision, and there's higher early failure rates due to femoral neck fractures. And the indications for this, meaning the patients that will qualify this, are very narrow, and it's a certain age range, males with adequate bone stock. But really, with modern hip replacement, that's kind of the mainstay treatment for hip arthritis. So we'll talk about that now. So what actually is done with a hip replacement? On the left here we have our arthritic hip. In the middle you can see the artistic rendering of hip replacement components, and on the right you can see the hip replacement components implanted. So we basically get down to the hip joint and we remove the ball or the femoral head, the part that's worn out, and then we turn our attention to the acetabulum or the socket, and we put in a metal cup that's usually some type of titanium mesh, and that the bone will grow into. In that cup, a plastic liner gets snapped in, and that's what the ball will articulate. And then we turn our attention typically to the femur or thigh bone, and we put in a stem that gets typically stuck in there that has a special coating that allows bone to grow into it. And then on that stem, we pop on a ball, and the ball is typically made of ceramic, and that's what articulates with the plastic liner, and that should hopefully last 25 or 30 years. So that's a very simple diagram of what hip replacement is. So, I always tell this all my patients: if you had to pick a joint to get replaced, whether it's a shoulder, elbow, hip, knee, or ankle, the hip is the one that most patients would pick. And that's for two reasons. Number one, it's typically a much quicker, less painful recovery compared to, say, rotator cuff surgery or knee replacement. And number two, and most importantly, once you're all healed up from the surgery, not everybody, but majority of patients will feel so good they forget they ever had it done. We call it the forgotten joint. The recovery is pretty quick. It's usually about 6 weeks. And like I said, it's one of the most successful procedures in Western medicine at improving patients' quality of life. And this is an x-ray of what the hip replacement looks like. So a common question is, what approach should I have done? What way do you get to the hip? And I tell patients, every total joint surgeon is biased, including myself, based on our training, education, experiences, and whatnot, but the outcomes at 1 year are all the same. And that's supported by the medical literature. And as you can see, that's from the American Academy of Orthopedic Surgeons. So at the end of the day, it does not matter what approach you have done, but like I said, everybody has their own experiences and their own preferences. So there's many different approaches. And what does approach mean? That's kind of the path or the interval that the surgeon takes to get down to the hip joint. And there's many different ones: anterolateral, direct anterior, direct lateral, superpath, and posterior. But the main two common ones are the direct anterior, the front, and the posterior approach or the back. And the direct anterior is the way that I do it. So we'll talk about that. So the direct anterior approach, what are the theoretical advantages of this? It's a muscle sparing approach, so no muscles are cut, and this leads to a quicker recovery in the short term versus the posterior approach, or from the side where they cut some of the gluteal muscles, which could potentially slow you down for the first several weeks to months. Another advantage is it's potentially a lower dislocation rate because we don't cut the hip capsule and some other small muscles in the back of the hip that gets cut when they go in through the posterior approach. So typically, at least in my practice, for anterior hip replacements, we don't put them on hip precautions. Hip precautions are this middle diagram seen on the right, and that's where the surgeon will sometimes tell you can't bend down and pick something up or cross your legs for however long they decide. When we do it from the anterior approach, unless something's unusual, we typically do not put patients on hip precautions, and it just kind of allows for a little bit easier recovery in the beginning. But again, long-term, there's no differences. Thirdly, another advantage is when we do it from the front or the anterior approach is you're laying on your back when we do the surgery, so we can take an x-ray before, and then we take an x-ray with temporary implants in, and that allows us to use computer-guided navigation to kind of overlay those images and very precisely restore your leg lengths and restore your hip mechanics. And typically when you do it from the posterior approach, the patient's lying on their side. It's not as easy to get these x-rays and not as easy to use this navigation. What are the disadvantages of doing it from the front or the anterior approach? And that can, number one, you can get some numbness in the side of your thigh. There's a small nerve called the lateral femorocutaneous nerve that branches out by the incision. And about 5% of the times, of 1 in 20 patients, sometimes one of those branches can get injured, and that can cause numbness in the side of your thigh. It's just numbness, and it's a minor nerve, typically goes away, so it's not a big deal. But that doesn't happen typically when you do the posterior approach or from the back. Another downside is for patients with a BMI over 40, sometimes those patients have a higher rate of wound healing problems and infection issues, so we typically try to get patients' BMIs below 40 before we do an anterior hip replacement. And then thirdly, it has what's called a steep learning curve. It's very difficult for surgeons to learn this approach that they haven't done before, and this can lead to a higher complication rate for their first several hundred surgeries. So you want to make sure you have a surgeon that's comfortable with whatever approach they're doing, because again, at the end of the day, it doesn't matter, but you want to make sure they're not doing their first anterior hip replacement on you, would be my advice. All right, so what else can we do to kind of speed recovery after hip replacement? One thing that most surgeons do nowadays is called multimodal pain management, and this involves giving you several different drugs that are not narcotics that attack pain in different ways, and this overall minimizes your pain, and this sometimes minimizes or even eliminates the need for narcotics. It leads to a safer, quicker recovery with less side effects from the narcotics. So if you don't need to take narcotics afterwards, it's much better, but sometimes you do. All right, and tranexamic acid. So this is something that most total joint surgeons give to all their patients. This is a synthetic analog of lysine, and basically it's been shown to decrease blood loss, decrease the need for blood transfusion, decrease swelling, lower the risk of infection, and most total joint surgeons that give this routinely before and after surgery. That's made a big difference, and there's strong evidence to support its use. The anesthesia, some people, traditionally we would do general anesthesia, but nowadays more and more surgeons are doing spinal anesthesia, and there's moderate evidence to support its use with a lower DVT rate, blood clot rate, lower blood transfusion rates, lower pulmonary complications, lower renal complications, improved short-term functional and cognitive outcomes, especially for I would say that the wiser patients, once you get up there in years, sometimes when they get general anesthesia, they come out a little fuzzy. So if possible, we try to do the spinal, and it doesn't affect them as mentally as much. And just because you're having a spinal doesn't mean you're awake for the surgery. They give you the shot in your back, your legs go numb, and then they'll give you medicine through your IV. So it's kind of like giving a colonoscopy where you're in a twilight, but you're not fully intubated with a tube down your throat and getting a lot of heavy-duty drugs. So a periarticular joint cocktail, this is a mix of different pain medicines we put into the soft tissues around the hip replacement at the time of surgery, and this really helps with pain early on in the post-operative period, and this helps for the first day or so. And then surgical dressings, nowadays most of us use some kind of waterproof surgical dressing. Some of these are impregnated with silver, and there's some studies that suggest that this may lead to a lower rate of infection, like this one here, but this was sponsored by I believe, the company that makes the dressing. So you can see there might be some bias with that. But these are nice. It allows people to shower right away and kind of keep the outside environment away from your incision that's healing. Betadine soak. So this has been shown to, if you soak the hip replacement or knee replacement once it's implanted with this betadine soak, it potentially can decrease the infection rate by 50%. So that's a big deal, and most surgeons do that. Another common question I get is, does the type of implant matter? And there's many different companies, DePuy, Stryker, Zimmer, Biomet, Medacta, Smith & Nephew, the list goes on and on. But does the type of implant matter? And for the most part, no. It's no. My expression that I learned from one of my mentors is, it's not the arrow, it's the archer. It's not the implant, it's the surgeon and how it's put in. That being said, you want to avoid adopting implants too soon, because sometimes there's recalls. For example, in the early 2000s, they thought it was a great idea to put on metal hip replacements, the implant companies. So they sold it pretty heavily, but it turned out, for some of those, it caused a lot of problems. So when you're getting your joint replaced, or if you're considering it, and ask your surgeon, like, what implant do you use, and make sure it's has some kind of track record to back it up. You want something that's tried and true and it's been proven to work, so not something that's going to get recalled. And then, so what are the modern hip replacement bearing surfaces? As I said, in the early 2000s, they did metal on metal. Prior to that, they did an earlier version of plastic that only lasted 10 years. But nowadays, modern hip replacement bearing surfaces is a ceramic ball or a pink ball. So even, sorry guys, but even men get this pink ball typically in the United States. And then the liner is a special plastic, what we call highly cross-linked polyethylene. And sometimes it's mixed with vitamin E. And that's been shown to last about 25 or 30 years, potentially longer. So that's typically what's done in the US. And then finally, outpatient hip replacement. So we're in the middle of a paradigm shift from hip and knee replacements being done in the hospital setting with an extended hospital stay and then discharged to a nursing home, versus nowadays, at least in my practice, a majority of these hip replacements are done in the freestanding surgery center, where you're discharged to home the same day. The surgery takes about 40 minutes to an hour, and you're up and walking, you have lunch, and you're home, sometimes before noon. And this shift was somewhat, in part, accelerated by COVID-19, but this is something that's been happening over time. But more and more hip and knee replacements were being done away from the hospitals, and there's benefits to this. Number one, most importantly, it's a lower risk of hospital-acquired periprosthetic joint infections. We only bring young, healthy orthopedic patients to orthopedic problems to the surgery centers, versus the hospitals. If you go in there and there's a lot of stuff going on, and sometimes people have these really nasty infections, and really these are just buildings that sick people filter through. So if you can avoid that environment for at least a hip or knee replacement, from an infection standpoint, it's better. Also, if you do it away from the hospital, it's typically a fraction of the cost compared to doing it in the hospital. It's just much more expensive to do things there. It's also nice just to recover in your own home with your own bed, and there's not people poking and prodding you and buzzers going off, and people keeping you up at night. If you can go home, then it's typically better, and patients are usually very satisfied with that. But this isn't appropriate for everyone. You need to have an adequate support system at home. You need to have someone staying with you, friends and family nearby. You need to be motivated. You have to have the patient that wants to do this, and you have to be the appropriate age. Traditionally, we reserve this for people under the age of 65. My current record is 82, but you want to make sure it's a healthy 82 with a good support system at home. So it all depends on the patient. We do it on an individual basis. You obviously have to be relatively healthy. You can't have multiple medical comorbidities, because those are the people that you want to do in an inpatient setting like a hospital. All right, so that's all I got. Thank you guys for your attention. I don't know, looks like I was 30 minutes, so hopefully that's what you were looking for.
Oh, I forgot to unmute myself. Yes, that was great, Dr. Schwartz. Thank you so much. Very quick, a lot of information. We've got a few questions, and I know more will be coming in now. So I'll start, and I don't believe I heard you answer this question. You might have. Bernard asks, how often can one receive a steroid injection for hip pain?
In my practice, I usually space it out every 3 months. Sometimes, it's 2 months and 2 weeks, and someone's going on a vacation or their wedding, and we kind of break the rule, but try to space it out every 3 months, because if you get it too frequent, it's not good for the health of the soft tissues or the cartilage.
Thank you. That's helpful. Andrew asks, If one has pain on one side of the buttocks, but it comes and goes away, does that indicate something to you, or do you need more information than that?
Probably need more information. You need to do a physical exam, get some imaging sometimes, and just kind of talk in further detail about, the pain.
Great, thank you. All righty. If someone is offered a custom hip prosthesis that's measured with having to have a CT scan, is that better than seeing a doctor who might do a prosthesis using just an X-ray?
The custom hip prostheses are usually done for very complicated redo surgeries. That might be for like a patient-specific reamer, but that hasn't been shown to be any better than the standard hip replacement. And I would advise you to not get the CAT scan. This CAT scan has, 200 times more radiation than an X-ray, and that has real, risk for developing cancer. So unless it's something unique, you do not need to get a CAT scan and have a custom hip replacement. That's no better than, the traditional way.
Great, thank you very much. If someone has a gluteus medius tear with hip osteoarthritis, does that make for a longer recovery from hip replacement surgery?
Possibly. It depends. Is the tear symptomatic? Is that something they're going to try and repair at the time of surgery? Because when you do a tendon repair, sometimes that limits your activity afterwards because you have to allow the tendon to heal. Whereas the hip replacement, you can usually put full weight on it right away with limited restrictions.
Gotcha. And are you able to sometimes do a repair while you do a replacement?
Sometimes, yeah. It really depends on if you think it's causing symptoms,
Gotcha. That makes sense. Marianne asks, am I wasting my money taking glucosamine and chondroitin?
Does it help you?
That's exactly what I was thinking you would say. Yeah, because you said.
I would say, if you feel like you're better when you take it, yes, but that's probably the placebo effect, but the placebo effect works. But I'm personally never going to buy glucosamine or chondroitin.
Gotcha. Thank you. That's helpful. And that's what you had said. You also mentioned that there were some adverse effects from that.
There's adverse effects to everything, but I would say I don't know what it is, but it's probably super rare. I think it's very well tolerated.
Okay, great. Thank you. All right. And do you offer PRP injections, or do you send people someplace else?
Yeah, we do them.
You do them? And can you do them on someone who's on blood thinners?
Yeah, we usually try to get people off NSAIDs, like ibuprofen Aleve, for a couple weeks beforehand. If you're on a blood thinner and you can't get off it, I suppose you could do it. But if you're taking like ibuprofen for pain, then we typically try to get people off that. But yes, we do them. I have a nurse practitioner that is excellent and draws up blood and does it all.
Awesome, super, thank you. All right, Jerry asks, ice versus heat, what is better for therapy to help in rear end pain lower than the hip?
I would tell Jerry to try ice one day and try heat and see which works better and stick with that.
Great,
or both.
Thank you.
I don't think there's a right answer on that one.
Yeah, it's pretty personal. Got it. Thank you. Someone asks, what exercises would you suggest to maintain my new hip that was replaced and my old hip?
Low impact exercises, cycling, swimming, elliptical.
Great. Thank you. Laura asks, how many total hip replacements have you performed so far? Do you have any idea?
I don't have an exact number. I did a lot in my training. My residency was a lot of joint replacement heavy, and then I did a lot over the year, my time at the Brigham. Nowadays, I don't really know exact number how much I do. It's probably somewhere on the scale of 600 to 700 joint replacements a year, and I've been in practice for about 7 years. So I've done thousands, but I don't know.
Yeah, got it. Well, that helps. Yeah, I know you mentioned you did hundreds every year, 600 or so. That we can figure that. We can do the math.
Yeah, I don't know that, but this is all that I do.
Yeah, gotcha.
I'm a very simple doctor.
One specialty. Come in, get your hip replaced, out you go. All right, let's see. Gail says she has a completely torn gluteus medius muscle. Would she see a hip surgeon or a sports medicine doctor? What's your recommendation?
You can see both. You know, that's the kind of a place where it overlaps. So some sports, you want to make sure the sports surgeon does hip stuff. Some sports surgeons do, some don't. I would say most people like me that are joint replacement specialists do treat that as well.
Great, thank you. Okay. Brian asks, what are some of the diagnostic tests that you would do for a person who is recently experiencing sharp pain in their hip?
Number one, we would get a physical exam. So the surgeon or provider should move the patient's hip around, see is there limited motion, what causes pain, etc. Two, you get an X-ray. It's oftentimes if you have arthritis, it shows up on X-ray, and you can stop there. You don't need anything else. If the X-ray looks normal and you think it's coming from the joint, typically you get what's called an MRI arthrogram. And that's where we put dye into the joint, and then you get an MRI. The MRI, there's no radiation. It's just a magnet, but that looks at the soft tissues, and sometimes it looks at the joint surface in better detail, and it can pick up things like arthritis that doesn't have an X-ray, or a labral tear, muscle, tendon issue, etc.
Great, thank you. Can a torn labrum be repaired, Judy asks?
Yes, but if you are older and you have arthritis, there's certain ways to grade it. If you have arthritis and a labral tear, it's usually treating the labral tear as a sham operation. You want to focus on the arthritis. If you're younger and you don't have arthritis, then you typically focus more so on the labrum.
Gotcha. Great, thank you. Okay. Gary asks, what is the best postoperative DVT prophylaxis? And I'm afraid I don't understand that question, but you might.
So after orthopedic surgery, there's a higher risk of blood clots, with hip replacement, knee replacement, other orthopedic surgery. So always do things to prevent that. So there's different medicines you can do. There's aspirin, Lovenox, Xarelto, Coumadin. So really it all depends on the patient. But if you're low risk, meaning you haven't had blood clots before and you're not on a blood thinner, most commonly nowadays, what people use is aspirin, 81 milligrams twice a day in combination with SCDs or something that circulates blood through your legs and encouraging early mobility. But really, it's done on a patient-to-patient basis because, sometimes you put someone on the Xarelto or the Eliquis, and that can lead to more bleeding, swelling, pain, infection versus baby aspirin, which is gentler. But there's studies that show it's just as effective at preventing DVTs and PEs.
Great. Awesome. Thank you very much. When someone has an autoimmune suppressed disease, how do you deal with them differently than someone who does not have an autoimmune disease?
Well, if you have autoimmune disease, you typically want to see a rheumatologist to make sure you're on the right medicine. Sometimes there's, a Humira drug or something like that can really slow the process. So in that sense, it's a little bit different, and sometimes they're a little bit more medically complex. But from hip, like doing a surgery on them, maybe their bones are a little bit softer, but for the most part, no.
Great, thank you. And I know you mentioned this, but Kathy asks, what would patient criteria be for an anterior total hip replacement? And can someone who is obese have this approach?
Yeah, someone who's obese that can have that approach. In my practice, the criteria is that they want to have a hip replacement, because that's what I do 100% of the time. I try to get patients BMIs under 40. Sometimes it's a little bit over, and they can lose the weight on their own. Sometimes they need to lose, some significant amount of weight, at which point we have a program in IBJI called Ortho Health, and that's run by a medical physician with a team of specialists underneath them, trainers, physical therapists, all different types of specialists, and they help people lose weight safely. People with bad hips, backs, and knees that can't walk, they can't burn calories, so it's tough. So we have that program in place. But typically, at least in my practice, if I'm doing an anterior hip replacement, I try to get their BMI under 40 because it's just safer that way.
Got it. Thank you. All right. Okay. Let's see. And I don't know what this stands for, so I apologize if it's not the right question. Do PPIs affect hip bone? I don't know. P as in Paul, eyes.
proton pump inhibitors, like a acid reflux medicine.
I don't know, maybe.
It might affect, the mineralization of the bone, which could lead to like osteomalacia, or osteopenia, or osteoporosis, meaning
Okay.
softer bones. But does it cause arthritis? I've never heard of that. No.
Gotcha. Okay, thank you. Garth asks, can I return to running after hip replacement?
That's a good question. I've had many patients that have had their hips replaced with me that run on them. I had somebody email me that they did a marathon a couple years later. Traditional thinking is you should avoid running and it'll help it last longer. But newer studies suggest that you can run on them. So what I tell my patients is definitely no running for 6 weeks. And if they are going to run on it, you think of it as the tread on your tires. If you're driving all over the place, you might wear it out a little bit quicker rather than, granny who's just driving to church once a week. But I'll leave it up to the patient. If they want to run that risk, then they can run on it, and that's fine. But yeah.
Got it. Fair enough. So it's, yeah.
When I say run, I mean like marathon running. I always tell my patients, you can run to chase a burglar or chase your dog or your grandchild. But if you're like putting, 10 miles on your hip every day running, I don't know if I love that. But, people do what they want, and that's fine.
Yeah, fair enough. All right. Can both hips be done at one time?
It can. It's a higher risk of, some medical complications like pulmonary embolism. So typically we don't do that, but in some circumstances we do. But typically we do whichever one hurts you more first, and then we let you heal and recover, and then you tell me when you want to do the second one. And oftentimes it's pretty quick. That way it kind of minimizes your downtime, but at the same time it's not putting you at any unnecessary risk.
Gotcha. Great. Okay. How about other sports limitations like skiing, pickleball after hip replacement?
There's no limitations. You can ski, water ski, pickleball.
Great. So and they don't have that impact that running does. So it's a little bit.
Yeah. I prefer patients that run on them, but I don't give them that restriction.
Yeah, got it.
If they understand that maybe it will wear out quicker, I'm fine with them running it as long as they understand that.
Gotcha. Fair enough. Let's see. If you've had a hip replacement and you undergo physical therapy but continue to have thigh and knee pain, any guesses? She says, what's the likely cause? But I mean, obviously you can't know that. But are there some things that you might consider recommending to someone to help them discover the likely cause of that pain?
I'd go to your surgeon that did it and ask them and have them take a look. Probably want to get X-rays of the hip replacement and probably want to get X-rays of the knee. If everything looks normal, you get MRI of the knee, and there's different tests you can get of a hip replacement that's painful. So I would go to their surgeon they want to see and have them take a look.
Great, thank you. And Jane asks, what hospital do you operate from? It sounds like you operate in an outpatient clinic, but I wanted to ask that for her.
Yeah, so I would say a majority of my cases I do is an outpatient. That's at Hawthorne Surgery Center in Vernon Hills. We also have another surgery center called Red Oak Surgical Suites in Lindenhurst, which is about 2 years old. So those are the outpatient places I go to. And then I'm on staff at North Shore, which I go to very infrequently. That would be Skokie Hospital, but I go there like at best once per year. A majority of my surgery I do at Condell, which is in Libertyville. And then I used to go to Lake Forest, but I'm kind of phasing that out of my practice.
Gotcha. Okay, thank you. Does the future hold any potential for alternatives to hip replacements, such as cartilage regrowth? Thomas asks.
Maybe, I'm sure at some point. Probably not in my career span, but maybe.
Maybe. There's research being done.
Oh, yeah. If someone can figure that out, they're going to be a trillionaire and win the Nobel Peace Prize. And hopefully someone figures it out one day.
Yeah, great. Do you know about how much a total hip replacement, what the cost of that is?
Well, it's a complicated question. Cost of the insurance, cost of the patient, depends on the patient's insurance.
On everything,
depends on where they do it. If you go to some hospitals, it's literally 4 or 5 times the cost of doing it in the outpatient setting. So there's a lot of variables. and what does the cost actually mean? So.
Right, exactly. Great. Okay, fair enough. I just figured, someone asks, I'll throw it out there. You might, that helps them to understand it varies.
I would say, any major surgery is going to typically max out your deductible for the year.
Yeah, fair enough.
Paying the full cost of the procedure, in the United States, if your insurance typically not, you're paying your deductible, which is smaller.
Yeah. Exactly.
Honestly, that's not something I typically deal with at all. So I would probably be the last person you want to ask that.
Fair enough. Yes. Yeah, that's the billing department. Let's see. What is contributing to the sharp increase on hip replacement to present day? You mentioned how it's going up so quickly. Is it due to the success rate, or is there another reason that perhaps that increase is going so quickly?
Yeah, I'm sure it's multifactorial. The baby boomers are getting older, their joints are wearing out, people are living longer, more active lives. Their obesity is common in the United States, and that can accelerate it. And the outcomes after hip replacement are certainly improved over time, and I'm sure that has something to do with it.
Yeah, got it. Let's see. For someone who needs a hip replacement, could that also potentially alleviate pain in the knee of the same leg?
Yes, absolutely. So sometimes we see people come in and they have knee pain, and they've had all these tests and injections, sometimes even surgery, and the knee looks totally fine. And you're like, what's going on? And then you move their hip and it doesn't move, and you shoot an X-ray and you see this horribly arthritic hip. And for some reason, some people's bodies are wired where they feel the pain in the knee, but really the problem's in their hip. That's what we call referred pain, because it's the same nerve called the femoral nerve. So oftentimes when we fix someone's hip arthritis with a hip replacement, a lot of the knee symptoms go away. And sometimes back pain goes too.
That's great. Thank you very much. That makes a lot of sense. All right, let's see. After replacement of the hip, are you able to correct, let's see, post-posterior replacement, are you able to correct the alignment of the lower leg? So so it says post hip replacement, are you able to correct the alignment of someone's lower leg? So I'm guessing their lower leg is misaligned. Would a hip replacement be able to help realign the lower leg?
Yeah, what I would say with hip replacement, we try to restore the hip mechanics, meaning we try to put your hip where it was when you were 18 before you get hip arthritis. And that involves leg lengths, meaning the length of your leg. Also the offset, meaning how far out is the leg from the belly button or the center of your body. And then sometimes you can correct the rotation of the leg in terms of internal external rotation, but that's limited. So I think the answer is yes.
Yes, or yes, maybe, depending on what's causing that lower leg alignment to be off.
Usually we think alignment more so in like knee replacement, where like if you're bow-legged or knock-kneed, then that gets corrected. But with hip replacements, I think of it more so as leg lengths and offset.
Yeah, that makes sense. Thank you. Let's see. Does the existence of a subchondral cyst in the hip mean you have hip arthritis?
That's a finding of hip arthritis, yes.
Okay, thank you. Let's see. Can you say more about the length, about leg length being restored? Like they're asking, what if their leg is already longer?
The one with the arthritis?
Yeah.
I mean, it's hard to say, over the internet. You really have to see the X-rays and kind of
see the person. Yeah, that makes sense.
I tell you that all hip surgeons always do their best to make the leg lengths equal. Sometimes there's limitations, we worry about stability and things like that. The way that I do things, like I talked about, I use this computer navigation. So we'll shoot an X-ray while the patient's on the table, then we put temporary implants in, we shoot another X-ray, and then we overlay those images. And then we have this, 2024 computer program that is able to overlay those images and tell us exactly how long and how much offset we want to give it, which is very helpful.
Oh, that's awesome. That's fascinating. Thank you. Very cool. Is it possible to have truncator bursitis and osteoarthritis in the same hip?
Yes.
Yep, I figured as much. Let's see. So do you use technology during hip replacement, like an MRI or a CT or computer or robot aided procedures?
I use, like we talked about, that computer navigation, and that allows me to put the parts just how I want them to restore hip mechanics. I'll get an MRI if the x-rays don't look that bad, and we'll get typically an MRI arthrogram, but I don't need that for, planning.
Sure.
That's more for diagnosis.
Gotcha.
And CAT scan, typically not. Again, you try to avoid CAT scans if possible. It's a lot of radiation, and
Yeah.
there are some, hip replacement products where people will you have to get a CAT scan before for preoperative planning. But in my opinion, that's all medical marketing, and it hasn't been shown to be any better. And you're placing people at a higher radiation exposure. So I don't do that.
That makes sense. Thank you. All right. Let's see. Do you primarily focus on the hip, or do you also do some knee surgeries?
I do both. I do hip problems and knee problems.
Okay.
If it's attached to the femur, I do it.
If it's, there you go. That works. I like that. If it's attached to the femur, Dr. Schwartz does it.
Yeah, so I would say, it's probably, I don't know, half and half, we'll say.
Okay. Oh, really? Okay, great. Thank you. That's good, because I think people are going to come to you for their knees as well as their hips after this program. Is a hip replacement possible if you have mild osteoporosis? Does it increase complications, or does that osteoporosis increase complications?
Osteoporosis means weak bones. So in theory, if you have osteoporosis, it's a higher risk of fracture during the surgery. But we operate on people with osteoporosis all the time. So maybe there's a teeny bit higher rate of fracture, at least in my practice. But I would say no.
Okay, great. And you already addressed that. So someone asked, how you mentioned that these new replacements last 25 to 30 years. What happens with the patient after the 25 to 30 years following the replacement? Does the implant fail? Do they need another surgery? Or we probably don't know, because these are new.
Hopefully it lasts longer. It doesn't mean it's going to fail 25 or 30 years. That's just kind of what the studies would suggest, but if it does wear out at 25 or 30 years, then oftentimes it's just as simple as popping out the plastic liner and putting in a new plastic liner, because that's in theory what would wear out at that point, unless there's some other issue or problem. But I think with modern bearing services, they're hopefully going to last a long time. And with the old plastic, the stuff from the 90s, that would wear out pretty quickly. With the modern stuff, we don't see that as much anymore by any means.
And how frequently do you do those hip revisions of those joints from the 90s that have worn out?
I do whatever comes my way, so it's variable,
Yeah.
But mostly do outpatient hip and knee replacements. That's majority of my practice.
Yeah, got it. And so majority is first time.
Usually, yeah.
Yeah, got it.
I do the revisions of the redos, but that's not a majority of my practice by any means.
Great, thank you. All right, and last question. Can you tell Kellyanne what factors will affect the longevity of a hip replacement?
Again, I would think of it as like the tread on your tires. If you want it to last forever, be kind to it, and do low impact things. If you want it to wear out really quickly, you can train for a marathon every day for the rest of your life. I mean, maybe that might make it wear out quicker. It might not. I don't know.
Gotcha. Okay.
You want to avoid falling.
Yeah.
So.
Yeah. Good call all the way around to avoid that falling, for sure.
Yeah.
So.
100%.
All right, Dr. Brian Schwartz, thank you so much for your time. Thanks for the great presentation. Thanks for all the wonderful information. We appreciate what you've given to us this evening. And folks, if you want to reach out to Dr. Schwartz, his information's right on the screen there. Have a great evening, everybody. Thanks, Dr. Schwartz, for everything. Terrific presentation.
Everybody. Have a great night.
You too. Thank you. Bye-bye.